Hello, hello, everyone. Good afternoon if you're on the East Coast. Nurse Scott, you're on the West Coast, correct?
Yeah, it's lunchtime.
Well, okay, so good afternoon if you're also in Nurse Scott's time. Today, we are going to be talking about the fake degrees. Nurse Liz has been gracious enough to let me borrow some of the FAANI committee. So, Nurse Scott, if you could just tell everyone what the FAANI committee is.
Well, there's a group of us that have been doing these panel discussions every Friday with Nurse Liz, and one day she said, I just feel like calling you the Academy today. I don't know where that came from. And we decided that it could be the American Academy of Nurse Influencers. And then if we were fellows in this academy, that would be FAANI. It's FAANI. So we are fellows of the American Academy of Nurse Influencers, the FAANI pack, I suppose, if you want to call us that. It's all in good fun. It's not a real organization, and we hope you have fun with it too.
Someday it might be a real organization.
We could.
And if you would like to see more of the FAANI committee or whatever we call ourselves, you can check out Nurse Liz's channel on Fridays between 3 p.m. and 3:30 Eastern Standard Time. And you will see Nurse Adrian there, Nurse Scott, and Mr. Midwife. And Mr. Midwife, you could tell us a little bit about yourself.
So I'm a certified nurse midwife. I'm practicing in the Southwest area of the United States. I deliver babies and love it.
And what is the name of your YouTube channel, Mr. Midwife?
Mr. Midwife. Yep.
And Nurse Scott, what about you?
Nurse Scott.
Nurse Scott. Perfect. And Nurse Adrian, do you have a YouTube channel?
I do. Yeah. It's all my social same. It's Nurse Adrian RN.
Perfect. And yeah, if you guys could in the private chat, just leave your socials and I will link them also to this video in the description below. And if you're watching the playback, the links will be in the description so you can see more of Nurse Scott, Mr. Midwife, and Nurse Adrian. So the fake degrees. And unfortunately, the more I read, the more disheartening it gets, because initially I just thought it was going to be Florida, but Nurse Adrian, I believe you had brought up that this is happening in other states as well.
Yeah, it looks like the nurses are in other states. What's not clear, and this is all really just poor reporting on the part of the journalists, honestly, is they're not saying, are these the nurses that are from this school and these schools in Florida, or are these just other nurses that they've discovered? So there's some gaps in the journalistic and integrity and quality, I would say. And it's very difficult to weed through this because, of course, these documents, there's not much to find. It's difficult to find anything because, the boards of nursing are not going to release information. It's challenging to fact check some of this and trace it back. But I believe that there are other schools that we are definitely finding that have been performed fraudulently on some level, or some level of fraud as far as taking the nursing boards, perhaps. I mean, there's allegations that, one of the owners of one of these Florida schools actually worked for the Board of Nursing in New York.
Oh, wow.
And so this Johanna Napoleon, allegedly, I haven't been able to verify this, nor have I had anything to verify. But I've been told by several people that she did work for the New York State Board of Nursing. In addition, she also owned several nursing schools from 2008. So her business listings have over 20 listings of businesses associated with different nursing schools and nursing programs registered in the state of Florida, Virginia, Maryland, Delaware.
So initially when this had come out, it was saying that it was 3 schools in Florida. And the update is also that Georgia nurses are pushing back against a request by the Georgia Board of Nursing to voluntarily surrender their nursing licenses, which is just preposterous. How do you push back on something you never earned? Mr. Midwife, you feel very strongly about this.
Well, so as I did some research on this, I found an old clip, maybe 1 or 2 years old. Some news station out in Canada had done an expose where there's a whole bunch of licensed, various degrees of licensure and stuff in Canada that they had gotten hold of credentials from diploma mills outside the United States. And so this whole nursing licensing, it's not new. it's probably more pervasive than any of us want to admit. And yeah, my feelings on this are absolutely strong. And of course, Adrian, you can speak to this. I can't. I think any quote nurse who has gotten their license fraudulently should be charged with assault and battery for every time they touched a patient. Every time they put their hands on a patient, that's a new count. And particularly, I get real passionate about this, particularly about people in my field. Anybody that worked as a labor and delivery nurse, considering where I have to put my hands and the things that I have to do, that should be escalated to some other kind of assault.
That really makes sense because you have to give
time. Every single time you put your hands on a patient or in a patient, that's another count.
And you have to give permission for someone to touch you, and if you don't, that's assault and battery. And people gave permission under false pretenses to those nurses.
And your permission is presumed by virtue of your license, and if your license was fraudulently obtained, then that's not consent.
Yeah, if you think about it, they gave their consent to be examined and touched to a registered nurse, and that person wasn't a registered nurse, so there was no consent. So yeah, I think that
precisely.
Something about this story that I thought it was interesting. I read through it, but then Nurse Liz brought up, I didn't realize that I thought the schools popped up as diploma mills and just sold these diplomas out. I didn't realize they had real students in real classrooms. And then on the side, there's a limit by the state board, as Nurse Liz was explaining. Schools are licensed to have only so many students per class. And then, so they had that, but then on the side, they were selling degrees. I didn't realize that. I thought they were, and that's why I think they were hard to find, because they had legitimate students. And that's why I think some of these nurses in Atlanta or in Georgia are pushing back, because they're saying, no, I was one of the ones that was in the classroom at an approved school, at a licensed nursing school, and I earned my degree, and you can't lump me in with the people that bought their degrees.
And that's where I agree with Nurse Adrian, because I'm just learning about this now. I didn't know that. I thought all of these schools were just issuing fake diplomas and that there was no education going on. So
it's debatable. It's debatable to the level of education, I would say. So, in my state, and actually close to where I live, one of these schools existed in Virginia. And it was owned by Napoleon and her brother and two other people. That was closed down. I don't know. Clearly, here's what we've discovered is that we cannot trust the states to investigate their own boards for licensing. We can't trust the boards to do their own investigations. The NCBSN has lost a lot of credibility, which are just members of nursing boards. And then we've got the accreditation agencies, which we have to look at, that are non-governmental agencies. This is a self-governing system that has completely failed. And the people paying the price are the patients, the public trust in nursing, and the taxpayers who have paid through Medicare, Medicaid money for services that have been fraudulently provided. So the only credible, in my mind, resource of investigation is really the federal government at this point. We really can't trust any state, because these boards of nursing report directly to the governors. There's a lot of pressure there, right, to not implicate a governor, not implicate, state leaders. So this is a sad part. We need to have this is a total overhaul we need in this system.
But I was saying to Bridget before we went live that I would lay money on the fact that there's a bunch of big corporate hospitals, clinics, other healthcare providers that are combing through every one of their people right now, saying, did we miss anything? Let's recheck every single person. And I would also lay money that within the next year or so, everybody who works for anybody is going to have to be re-fingerprinted, resubmit their credentials, redo everything, just to make sure that you are who you say you are.
And if you're just joining us, so the U.S. Department of Justice, it recently announced charges against 25 owners and operators of these schools. And so far, again, this number could change because this is a continuously evolving story. It was 7,600 fake nursing degrees. Of those 7,600, 2,800 passed the national nursing license, which I had done the math earlier. It was some 30%, like 34% of the 7,600 that took the NCLEX passed. The argument there is, how did these people pass? Some of them were LPNs. There's also an argument that perhaps they were nurses in their country. The article had mentioned that this primarily it was in the Miami area, but again, we're finding out more. It is, as Nurse Adrian said, is just so convoluted right now. It's hard to know what is true, what is going on. But it was saying that this scheme primarily targeted South Florida's Haitian American immigrant community. So I just encourage you again. I know it's hard as having parents of immigrants and knowing a lot of people that are immigrants, people that were vets in other countries, for example, Venezuela or Cuba. I encourage you to always operate ethically and to not take shortcuts, because I've worked with two MDs that were MDs in Cuba, and here they just decided to become NPs because their education was not recognized. So maybe something along those lines occurred.
But that's still legitimate. So that's the difference. I like something you said on one of your previous broadcasts, Bridget. There is no shortcut to anywhere worth going.
Mm-hmm.
I like that a lot.
Thank you. So
And
how
there's no release of liability of the law. Again, it is unfortunate. However, there is no doubt that this is intentional. Nobody. I'm going to stick to my guns here that the only victims are the patients.
Yes.
Because there's, I
There's
don't
no
need
excuse for it.
I know I can't drive 90 miles down the highway, right? It's like you're not immune from the law because you don't know the law, but you are expected to know that if you're going to go into any profession, right? I know I can't just go out and say I'm an electrician because I need a license in my state. Not every state do you need a license for that, but that is the burden of the individual going into any profession to understand and know what is required to do that profession. And all that information is readily available.
It's difficult when you're coming in from another country, you don't speak the language. I guess you could reasonably assume that nurses have to be licensed. But I mean, think of if we went to Canada where they speak the same language. Do you know what the licensing requirements are? Do you know how they'll apply? Do you know what kind of education you need? You assume it's like where you came from, but it may not be. Yeah, I mean, if nothing else, though, they should have known, oh, wait, you're handing me a degree and I didn't have to do anything for it. That, I think, yeah, everyone should have recognized that.
Especially they said they were charging between 10,000 to 15,000.
Oh.
What was that, Nurse Adrian? Adrian.
Oh, she's frozen.
I think she froze. So they were charging anywhere between 10 to 15,000 per degree. And I think I would say 99.99% of these people knew what was happening. They knew this was fraud.
Yeah.
I'm not sure how you can
have to do anything. That's common sense.
I'm not sure how any breathing human could say this isn't fraud. Anybody who went through this, paid the $10,000, got a diploma in the mail a few days later, there's no way they could think that's legit. There's just absolutely no way.
So it looks like these schools were once accredited, which is what you were saying, Nurse Scott. So they were accredited by the Board of Nursing, I'm assuming, but they were not accredited by the Commission on Collegiate Nursing Education, and they were non-AACN members. And these credentials, the AACN membership is voluntary, but it just sets a higher standard. It's similar to, for example, like a hospital attaining magnet status. It's just that level of, it adds that extra level of knowing this is legitimate.
And a lot of times to go to another degree, you have to have graduated from an certified program that has one of those extra certifications.
I was just about to say that. I had a lady friend who graduated from a non-AACN accredited school, couldn't get into graduate school, could not get in. She still has a nursing license. She's had a nursing license for 2 decades, but she can't go on for further education.
And see, this has changed now. So this used to say 5 to 10. Now they're saying 6 to 18,000, and it's saying in that these individuals were Maryland and Virginia. So again, this is constantly updating.
I think we're going to find this goes much farther and deeper than anybody wants to admit, which is why I say there's so many of these big corporations that are going to be combing through. If they're not doing it now, they will be combing through all their stuff, requiring us to re-fingerprint, requiring us to resubmit our credentials, so on and so forth, just so that they're covered.
The state should be doing that too.
It's just so scary. It says some of these, and that's the other issue. This is not just a Florida problem. These people were working all over the United States, Ohio, with pediatric patients in Massachusetts, at SNFs in New York, New Jersey. So this, like you said, this is just
to be clear, if anyone is just learning about this story, a lot of these, not all of them, a lot of these were LVNs. And so they had some nursing knowledge. They weren't able to operate at the level of an RN, but it's not like they were working at Starbucks one day and the hospital the next. So, which is probably how they passed the board.
Oh, well, wait.
Do we have
Scott.
information on that?
Oh, but wait, it gets better.
Come on over to TikTok. Come on over to TikTok, because we've had some of them come in our lives and fess up.
Really?
So many of them have been in our lives. There's about 3 or 4 of us that have had several of them in our. Well, they've given us information. Several of them stated that they went to the one-day LVN school prior to going to the buy your RN license school. That there's a one-day LVN school. So, that statement made by the U.S. attorney was really bothersome in the press conference, because, one is basically, we don't think any patients have been harmed, and some of these people had LVNs. Well, he really shouldn't have even said that, because they haven't even talked about that in the press. And again, this is another failure of journalistic integrity, that it's nurses that are reporting more on this. We are reporting more on this and getting more information than actual journalists are. They're just copy and pasting press releases from the feds. So I do want to say that. So that is how a lot of us have gotten some inside information that, again, we don't really want to broadcast because we don't have it. We want to verify things, right? But again, that's why I've put out the feds, the FBI's report line, the OIG's report line on my social media, because if people have more information, they should report. And certainly in the comments, you can tell in some of our videos, there are people that are these nurses.
And have any of them said how they passed the boards?
No, they have not. But again, I could pass, if I study hard enough, I could pass a contractor's license.
Yeah.
If I study hard enough and I know enough math, I could pass an electrician's license. You know what I'm saying? So it's not that, if you study enough and you do enough, review courses. But again, there's this allegation that some of these individuals worked in the Board of Nursing in New York. It wasn't just that you could take the test repeatedly, right? So if I took the test 10 times, I'm going to have a pretty good idea of the questions on it, right? But it also, if there's some insiders, and I guarantee you has to have been insiders in the Board of Nursing in New York, then, and because some of these people were told to go to particular test sites.
Oh, wow.
So this is a very important clarification that hasn't come out in the press, but we have heard this repeatedly in the comments and messaging. So several of us have had direct messages from people who are basically like freaking out, like, I know I'm guilty and I don't even know what to do. Will you talk to me? We're all like, nope, absolutely not. Go straight to the FBI and turn yourself in. And they've shared a lot of information, but we're like, nope, don't want to hear it. I don't want to be complicit in a crime. And I will advise any nurse, anybody with a license, we are mandated reporters, do not engage in conversations with these individuals. Direct them to the FBI.
When you took the NCLEX, here in Florida, they do palm scanning, which is supposedly more even like more secure, like has more security than fingerprinting. And so is it that they were just allowing them, like they were taking the test and then there's someone on the inside that was saying they passed when they didn't pass? Or
No, I think what it was, and again, I'm piecemealing together conversations other people have sent to me and shared with me, as well as what I've heard directly, is there was either something with the timing, the ability to look up answers to questions. So it's the proctoring part. It's the
so the
proctoring part.
proctor there.
It's like, here, let me just look on my phone while that question pops up and see what the answer is.
Wow. Because again, when, I just refer back to when I took the NCLEX, we could not have anything on us, no phones, nothing, like no pieces of paper. I mean, everything was in a locker far away. So I mean, if they paid off the proctor and then they allowed materials, or there's a breakdown in the process.
Right.
Yeah.
Getting through an airport is easier than sitting down to take the NCLEX.
Mm-hmm. And
And
that's why
sitting for board
As it
exams,
should be, maybe.
sitting for board exams as an MP is the same thing. I mean, we went in with nothing, absolutely nothing.
And that's why when someone was saying that there was someone on the inside, I'm like, but how? Like, how could they when they're so strict? But so, and how to the general public that maybe is interested in becoming a nurse, how can they avoid these scandals? What are some pieces of advice that we can offer them? Or
Well, if it looks
potential
too good to
nursing-
be true, it is. That's the old thing. If it's too good to be true, it's too good to be true.
I think looking at
Within
accredited
reason, because I
schools-
went to WGU and I thought, this is kind of too good to be true. You mean I can just study the course and then take the test and I've got credit for it? And then once I looked at it, I'm like, no, this is legitimate. Yes, sometimes some of those classes are really easy. You kind of look through the material. If it's something you already know and you can pass the test, you get credit. But not all the classes are like that. When, like for the RN to BSN completion, you have to do papers and you have to go out and do community evaluations for community health and things like that. So at the first blush, I was like, this kind of sounds too good to be true, but it is a different model. But if you're not expected to do anything and get a degree, that's too good to be true. And that's always a red flag.
And I saw this too, that Florida has one of the lowest passing rates in the United States. And hopefully with the nursing scheme schools shutting down, the pass rates will increase. But there was thought that also in general across the United States, because after the COVID pandemic, no clinicals, that was one of the reasons too why NCLEX pass rates just fell across the board.
I would agree
Well,
with
you
that. I
can't
think
be-
it's more because I don't actually think it. I mean, given that if there was, I mean, I don't know how many thousands of these people did the test in Florida, but I mean, they were directed to go to New York to do their
Mhm.
NCLEX. So I don't know the totality of how many people have taken the NCLEX that those numbers are based out of. So I would
Mhm.
tend to agree with you, Bridget, that this is a deficit based on the level of education or lack thereof
Mhm.
during the pandemic, and also the dumbing down of nursing school and overall, and hopefully that is not lasted
Do you think that,
currently.
and there was, so the consensus was we cannot dumb it down because they even though NCLEX rates have declined, we can't dumb down school because we have the patients' lives are in their hands, etc. But do you believe that some schools have dumbed it down?
Oh yeah, absolutely. Absolutely. I mean, if students, a lot of these COVID nurses, are great nurses. I'm not saying they're not, but a lot of them have been were fast tracked into critical care, didn't have full clinicals, don't really even still understand the totality of patient care. They understand the mechanics of nursing, but not really the totality of patient care and case management and really the bigger picture, right? And or they've had to learn that and be, if they're motivated. But certainly my understanding was that from what people have told me that took the NCLEX in the last couple of years is that they took an abbreviated NCLEX, they took a somewhat diminished NCLEX. They're the skill level, the skills coming out, which may not be reflected so much on the NCLEX as far as skills versus didactic knowledge. So again, those are two different things.
I did hear that they made it shorter briefly during the COVID pandemic. And when I made a video on why the video was titled like NCLEX pass rates have dropped or something like that. And someone commented, wasn't very nice, but was like, the reason why rates have dropped is because not because we didn't have clinicals, it's because they're making the test harder, and you saying blah 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 is so cringe. And honestly, I don't think that the test is harder. I just think that it may be different because they change things around, but I don't believe it's any harder. And if anything, with the next generation, they're going to be given partial credit for select all that apply, whereas previously we didn't get partial credit.
Right.
Well,
I think
the exam has to get harder as time goes. I'm sure that if I sat down for the NCLEX today, it would be much harder than the NCLEX I took 30 years ago. So it needs to change with the times, and nursing is more complex, and there's more to know. And so it is getting harder. Now, whether it should get much harder, like 1 year to the next, I think is what he's talking about. But the schools have to keep up. I mean, it's good that the NCLEX is kind of the bar, and then you can dumb the schools down if you want, but then your pass rates are going to fall, and that's a huge thing. That's what you need to look at if you're shopping for a nursing school. It's too good to be true, but then also see what their pass rates are. And if it's something abysmal like this, that's a red flag. Same with NP programs, graduate programs.
So,
nursing is not for everybody.
Mm-hmm.
Let me just be clear, you guys. Nursing, anybody watching this, it's great. You think, oh, great, I can make so much money. Go be a longshoreman. Go be an electrician. Be a plumber. You'll make even more money and have less injury. Nursing is about patient lives. It's about people. It's about humans. It's not just about money. And it's not an easy pathway by any means. And it shouldn't be, and there's a lot of us who are really advocating that there should be annual exams, even to keep yourself in the school. Some programs have that. We had to pass an exam, and it shouldn't be like the HESI or some other crap that just they're making money off of nursing schools and passing that on to students. But, just like the USMLEs, right? The medical doctors have to take an exam every year to get to the next year of school. There's a lot of us that are proponents of that. But as far as looking at your school, absolutely go on the Board of Nursing or the NCBSN report. They have jurisdictions. I don't know if they break down by state. Look at the pass rates for your school. How long has your school been in business? How many students do they have that took the test? Call the school and ask them how many students are applying, how many are accepted. Of the number that are accepted, how many actually graduate? Of the number who graduate, how many are actually passing? Because again, the number you're going to see on the NCLEX pass rate is only the number of students who pass from that particular year. It doesn't tell you, well, there could be, maybe they have a 97% pass rate.
Look at this one, supposedly 100% pass rate, but only one person took the test. So you can't
exactly that. and schools will weed you out, right? So my school, I went to the third highest pass rate college in California, a very well known. It was a community college. They flip between 1, 2, and 3 on the pass rates, and but what they. And it wasn't like they took a lot of people. They didn't. It was very tough to get in. However, they weeded you out pretty fast if you didn't have what it took. And when I tell you it was boot camp for 2 years, I'm not even kidding. I can call anybody up that I went to that program with right now, and they will be like, yep, it was boot camp for 2 years. It was hard.
And that brings up another good point. If NCLEX rates are dropping or are low, then maybe raising the entrance criteria, right? GPA of this much, GPA, certain maybe T scores. Nurse Scott is going yes or no, but I do know.
Well, I only do that because we don't know for sure that GPA is predictive of NCLEX success. And if we show that, if we do a study and we show that, that's fine. But it's always hard to know. It's like college entrance. Is your GPA, is your whatever, is that predictive of success in college? And your SAT scores. That's why a lot of them stopped using them, because one, they're racially biased, but they're culturally biased. but also because it's not necessarily predictive of college success. You have to look at
And
some.
that, so that would be a good area of research, because this is just another educator that I know. Her school dropped the like the entrance requirements, and she did tell me that ever since that happened, NCLEX rates have dropped. But that's just one person, right? One
That's
school.
anecdotal, but that's a place to start, right? That's how research
Mhm.
starts, with some anecdotal observations.
Mhm.
Adrian, before this passes, I want to make, you may have brought up a good point, and I don't know who I'm quoting, and I hope it's somebody I agree with, because it's possible that I'm not. You have a lot of freedoms in this country and a lot of rights in this country. You don't have the right to have whatever job you want.
Mhm.
You have to earn your way into certain jobs. You have to be able to do a job. You can't just be in a job because that's what you want to do. And especially these higher skilled jobs like in healthcare, you have to be able to walk the walk and talk the talk. And if you can't, that's okay. There's somewhere else for you in the world. I mean, on the one hand, out of one side of my mouth, I'm saying, everybody, please come to nursing. It's a great profession. We need more nurses. And on the other hand, I'm going, don't come if you can't do it. But that both things really are true. We need everyone who can to consider nursing as a profession. But for those that can't, don't want to, that's okay. There's no shame in that, I think, is what Adrian has said before. Actually, there's no shame in that.
And this debate goes on a lot on TikTok, I know, about LVNs versus RNs. And there's a lot of, oh, you're throwing shade and this and that, which none of us are. But this speaks a lot to vocational education, for one, which we have just lost in high schools, right? We've lost vocational education in high schools that help people, whether it's, and the same thing is true. And I'm not, a huge fan of all industries, but the same thing is true even for police departments, right? They cannot find qualified applicants. I've heard this over and over again from people I know that work in police departments, and they're like, what are we going to do, right? But again, if you have vocational programs that teach people, the wood shop, the engineering, the electrician, the plumbing, the nursing, the trades, right? And that we've gotten ourselves so elevated up into like, oh, we're professionals, we're not tradespeople. Right? Really? Well, when I'm wiping somebody's bum, it's like, let's just be real. Like, we have a trade that we do that is very skilled, right? And it doesn't really matter what category we think we're in and what our education is. There is still the basic level of knowledge that we all must have at some point to get to that next step. But we've got to start bringing in quality people into these schools. And I didn't have to do volunteer work, which a lot of schools required, which I thought was rubbish. I didn't have to be a CNA, which again, I think is rubbish. I didn't have to take the T's, which is total, absolute rubbish. And, I think that there are other things that we can do, like the Los Angeles County school system, the nursing school, they have an entrance exam. I felt like that entrance exam was very reasonable and something that I thought this is something that could be adapted for many schools. Now,
I want to see the research. I want to know, is that predictive of success in the program? If you're going to require that at the beginning, there has to be a reason for it, right? And not just so that for the appearance of being selective. It may or may not be predictive of success.
And there's a lot of subjectivity in nursing school, right? I mean, I got kicked out of nursing school. I dealt with homophobia. We dealt with racism. So, and just on top of it being extremely a grueling program, a lot of us dealt with some other factors. And we all know if they don't want you in nursing school, they will weed you out in clinicals, because in clinicals, they can get rid of you for anything. They would come up to our face, and I mean like boot camp face, and say, I can get you out now. Today, I can have you out. And they would tell us that. And I've seen it happen to so many students, which is so it's hard when you talk about like predictors and stuff, because we don't have a real fair, equitable system. And these these nursing programs, just so folks understand, operate very autonomously, even in whatever university they are housed in. The universities basically tell that director of the chair of that department, have at it. You're basically running your own college inside our university, and there's like zero accountability.
Well, you're right. It may not, whether or not you get through the program may be subjective, because you have to, go through the hoops of whatever clinical instructor you get. But it could be that the research looks at, is that entrance exam predictive of success on the NCLEX, which would be independent of how fairly the school.
And that would be what they need to be utilizing versus just random testing that doesn't equate with passing the NCLEX.
Yeah. And we've seen that in other fields, like with college entrance exams. So,
and yeah, nursing school can be very, very subjective. So there was, and some people are just excellent test takers. There was someone that in my nursing program that was just cruel to patients. Nurse Scott is raising his hand. There's someone that was in my nursing program that was just cruel, but she could ace the exams. And I'm like, this person should not be a nurse. This person should not be a nurse. They're going to make the worst nurse because they're just treating patients so poorly. Knowledge isn't enough to be a nurse. And then I had a dear friend. I think he tried like 2 or 3 times to pass a certain semester. And then if you don't pass, I think with twice, you just fail out of the program. Like they only give you so many opportunities. And he was excellent. He had great bedside manner. He could do his head to toe, but he just was not a good test taker. And he also, we were talking about the bias on test taking, the cultural bias, and he was not a white American. So, but he was from the States. He just couldn't pass these tests. And I personally have struggled with standardized testing, even though my test grades are normally like all A's. But when it comes to standardized tests, I've had to really, really study for the test, not so much the material, but for the test, so that I can get good grades to be comparable to entrants for my counterparts.
Test taking is a skill all in itself. Just to be clear, I'm a really good test taker, but I'm not bad to my patients.
I know.
I was like, yeah, that's me. Oh wait, no, that's not me.
Never mind.
But test taking is a skill. I've taken a lot of tests, and honestly, I think that it may be why I passed the test for Mensa, is because I'm just a really good test taker and I'm skilled at that. Although that was hard, so maybe I did earn that. But if you're not good, it can work the other way. If you're not good for it, you may know your stuff, like your friend, from school, that maybe would have been a great nurse, but did not get enough training on how to take a test. Or maybe test anxiety is also an issue that comes up.
And unfortunately, with clinical instructors, depending on who you get, I had, like, for example, a sweet clinical instructor, and another friend, she just had something against this person and basically failed him. So it's so. And so if you're watching this and you failed out of nursing school, maybe try a different program, because it can be so subjective depending on, and then once you get that bad reputation, oh, this student failed here or whatever, hopefully educators don't hold that against you. But if they do, go to a different school.
But, kind of circling back, getting that degree in your hand, passing the NCLEX, all that says is that you have met the minimum standard of education, training, and competency. Now, I've said this before on Nurse Liz's channel, and Scott tends to disagree with me on this, but there are certain people who are alive today because of what I either did or did not do in a certain given moment. That knowing what to do or not do comes with education, training, and experience. Mm-hmm. In that moment, in that split second, 30 seconds, whatever time it took me to assess the situation and decide to either move, not move, do, not do, comes through education, training, and experience. If these folks have cheated their way through that process, or at least part of the way through that process, they don't know. I read one of the articles prefacing this, that during the COVID situation, there was a situation where the nurse looked up to this new nurse and said, "Start CPR." And they looked back and said, "What? What's CPR? Oh my God. CPR is the absolute base minimum of what you should know how to do if you're going to be even walking in the hospital. Even security guards know how to do CPR. Yeah. If you don't know how to do that, you've got no business wearing the badge that says RN, LPN.
And that's where
I could have a moment to rebut.
Real quick before I lose my train of thought, I think that what Mr. Midwife just said was perfectly succinct, and what I wanted to say earlier but completely forgot, and goes back to what Nurse Adrienne was saying, that she said that to our knowledge, no one has been hurt. they have no idea, because these people were not able to make these judgment calls. Oh, maybe this patient is hypoglycemic. Maybe this patient needs to, we need to call rapid response or start, the hyperkalemia protocol or anything. We need to call the doctor for ammonia. Because their ammonia is elevated. We need lactulose. Like all these things that they have no idea how far the ramifications of these people not knowing their material, what it led to, unfortunately. And maybe we may never know.
And the death certificate reads cause of death, COVID. There's no other way to define that. We may never, exactly. We may never know. Probably won't.
Well, for one reason, we don't know who the nurses are that we're talking about. And second, we don't know what contribution they had to a patient's demise. Even if we say this nurse was on the case, patient didn't do well, would they not have done well anyway? I mean, we'd take a huge investigation. If I can rebut, where Mr. Midwife and I disagree is that I don't disagree that he has saved lives. And especially in your role as a nurse midwife, knowing what to do in a crisis, really the outcome hinges on your decisions. For me as an ER nurse, I've never felt like anything really hinged on my decision. I made some good calls. And maybe I just don't, well, I was going to say I don't like to brag, but I'll brag about Mensa, but I won't brag about saving lives, because I think it's always a team effort, or it has been in my experience. So we disagree because we've been in different specialties. And I think that especially, and you've been in advanced practice, and advanced practice obviously does, the results hinge on your decisions.
And
I'm sure you've made
with
some
Scott.
calls though, Nurse Scott. I'm sure you've made some calls where if you hadn't acted the way you acted, maybe the patient, there would have been like a patient demise in some way.
That is exactly what I'm saying, Bridget. Scott doesn't give himself enough credit. I would lay money on the fact that there's been countless times when whatever decision he did or did not make at that time, there's ramifications for it. Like it or not, there are.
Mhm.
And like it or not, Scott, you have been responsible for people being alive today because of what you chose to do.
Absolutely. Hey, I worked tele for 12 years. I for sure directly saved hundreds and hundreds of patients. We trained new doctors. We alerted physicians to things that were overseen. I mean, yeah, you have a team approach, but I was very lucky to work on a unit that was very highly skilled. We all shared our knowledge. We lifted each other up. We were almost competitive to a point about our knowledge base, and because it was how much do you know in cardiology, pulmonology, nephrology. I mean, you're a jack of all trades on tele, more or less. And so I would say that's the kind of environment.
As finding something like
go ahead.
It's as small as finding something like, this EKG just doesn't look right. It's the readout says normal sinus, but it just looks funny.
I do remember times I've known the right thing to do, but I'm not sure it had an out. Right behind the ER where I was working here in San Francisco, a guy fell off the loading dock. So that's, loading dock. And people were like, oh, get him up. I'm like, no, you leave him where he is. Somebody go and have one of them bring us a backboard. You don't move. Can you feel your legs? Can you feel your feet? And so because I had some pre-hospital training, I knew how to handle that. And I thought, good for me, especially I was working registry.
Take credit for that. Own that. That's you.
I think he would have been okay anyway. It's not like he had a cervical neck fracture, and thank God I put him on a backboard because now he's not paralyzed. But there have been times when I've definitely gone, pat me on the back because I knew what to do. I'm not sure it made a huge difference, but you're right. Over the years, somewhere maybe.
We bang on the ER nurses, but we know you guys know what's going on.
To Scott's credit, my little girl broke her foot a couple of months back. I'm a midwife. I don't know what to do. Who do I call? I get my friend Scott on the phone. I say, I'm panicking here. What do I do? And he's like, take a breath, calm down.
Yeah, I don't know that I saved.
I called the one guy that I knew that I could call that would at least get me clear-headed about it.
I calmed Dad down. I'm not sure I saved the daughter's life, but I did calm Dad down, and that's.
But I knew who to call.
Yes, you did.
So, how's she doing?
She's fine now. God can't stop her.
Nurse Adrienne, I think it was you that had brought up that you wanted to at least bring up something nice or positive, right? It was you?
Yeah. I was
so we can end on a positive note. How about maybe whoever would like to share maybe a different video? We could do a video where we talk about one thing we noticed that actually saved a life or prevented a patient demise. But if anybody wants to end us with a feel good story of how you helped someone.
Sure. I have a story that I tell a lot of people because it really is about critical thinking and collaboration. And it was a patient who came in. I worked in an area that was a lot of immigrants, farm workers, and oftentimes our patients would not speak English. Oftentimes they didn't speak Spanish either. They were Mixteca. We didn't even, we literally had no way to communicate. We had a gentleman come in. I believe he did speak Spanish, but he was more or less kind of just, disoriented, not able to communicate very well. And he was just kind of tracked into this assumption that, oh, he's having withdrawals or seizures or some kind of overdose, or the way he was presenting. And I talked to the doctor, and I wasn't really happy with the physician's approach to the patient. And there was things that just weren't adding up. It didn't look like tremors of a withdrawal. It didn't quite look like seizures. At the time, we didn't have a very robust neuro program to do EEGs. And, it was basically like, well, just let him hang out on telly and we'll check him tomorrow kind of thing. And as I'm looking at this patient, I'm realizing he's having rigor. He's having, my first thought is, does he have tetanus? Like what's going on here with this guy? And I called some of my friends on the floor and I said, hey, can you take a look? And they spoke Spanish. Can you see if you could ask him some questions? Because again, we didn't know if he had a drug of choice, what he had been on. We just didn't know anything. And then we had a friend who was actually gone through nurse practitioner school at UCLA. She was working. I called her. We were like, let's call blank. So, okay, we call her. Hey, come down here. Just run down here. Take a look at this patient. Again, I can't get the doctor to call any specialists on board. And if you guys don't know this or watching, a specialist cannot come to see a patient unless they are contacted for a referral by the primary physician or provider, even if you already have a cardiologist outside the hospital. So 5 of us get together. We start looking up online whatever we can about symptoms. And we come to this conclusion that he has botulism poisoning from bad heroin, of which there had only been 3 cases in the United States of that year. So there's very few botulism from bad heroin cases. And we're like, this has got to be it. This has got to be it. This person is going to perish by the end of the night. They're not even going to see tomorrow. So I went around protocol. I called another doctor I knew who was a pulmonologist and had gone to some other specialties, infectious disease. I said, hey, we have this situation. Maybe you can just call this other doctor and just say, hey, I'm really curious. I heard you may have this case. And can you get on, there's ways you get a doctor to get on board, right? So he gets on board. Boom. The next thing, it's like, hey, great job. We're on the phone. We're calling the CDC to get the serum. So I'm in California. The only place that has a serum is the CDC across country. So they have to get that serum on a plane immediately, get it to LAX, and then the highway patrol have to go pick it up and then like zoom with lights flashing up to our hospital, which is, 100 miles north of LAX, to save this guy's life. So that was a situation where it exemplifies exactly why we have to have critical thinking as nurses and collaborate and always question what we see. Does it add up? Does it add up?
Wow, that's an amazing story. And what I would like to highlight is when I was teaching, I would get a lot of students that their mindset is, I'm just going to get into nursing. I'm going to follow doctor's orders. I'm just going to give out some pills and go home at the end of the day and get a check. And it is not that. I mean, the fact you basically saved this patient. I don't know of a doctors have so many patients. They're not going to sit there and analyze that one patient like you did to try to figure out. I mean, you basically like Dr. Housed this case, like, so you basically are like,
pretty
what
much
could this be?
It took 5 of us nurses, right? I mean, I got really experienced nurses. I even called the ICU, and it ended up, we were like, let's call our friend who was med surg oncology, but she's a nurse practitioner at UCLA. boom, she, got us onto some other website that gave us more resources. And because we were in an area where there was kind of a little bit of a heroin bump, it wasn't out of the ordinary. It could have happened. But again, we're talking 3 cases recorded that entire year.
And talk about the initiative that you took. And I would really encourage other nurses that get into this field and this is where a lot of people, there's the back and forth. I think that compassion is so important, because I feel that when you have compassion, like you did, Nurse Adrienne, it will drive you to not judge the patient, to try to help them out. And if that compassion is lacking, it's hard to, I wonder if another nurse without compassion would have gone above and beyond like you did,
Yeah, if you don't have compassion, you don't care. You're not going to go that extra mile.
Exactly. And that's so true. And I know the people I worked with, I mean, 90% of them would have easily probably figured it out and pushed back on it, looking at the symptoms, because that's just how we were on our unit, because we had that because we let me tell you, we went through 26 managers in 12 years. We lost all of our nurse educators during the time I worked there. They cut the department. We had to be very aggressive about educating ourselves, and we had a very high standard for everybody who came in. And if they didn't meet that standard, we figured out a way to get them out of our unit.
Bridget, you bring a good point, and it came up actually when I was making my video on how not to lose your license. You cannot use the defense, well, the doctor ordered it. If the doctor orders something that's going to be harmful and you're like, and you give it, you can't say, well, the doctor, the Board of Nursing, at least in this state, the information I got, the Board of Nursing expects you to be aggressive in keeping your patients safe. If you notice something that's wrong, it's not, well, I've mentioned it to the doctor and I charted, I mentioned to the doctor, but he ordered it anyway. I'm going to go ahead and get it. You're expected to be aggressive and go, no, I really know this is wrong. I'm contacting my nurse manager or the nursing supervisor. I'm trying, if you still have to give it, fine, but you need to put up a fight. You're expected to put up a fight. It's part of what you do. It's part of what we like to do. I think we like to solve problems and solve mysteries, and we don't, we're not averse to confrontation. I mean, all of us have gone up against providers and said, you can't order this, and or how can we fix this, or I need you to order something that you didn't order. Some of us kind of thrive on that. You're right. If you're expecting to go into it being, I'll just do what the doctor says and go home.
You don't have to think and just kind of be a robot. It doesn't work like that.
No, it does not work like that. And you'll get in trouble. You'll lose your license that way.
Or there's the nurses that think that they are a doctor or just want the approval of a doctor. And, I mean, again, and it doesn't really matter how high you graduate. I've worked with so many top of their class nurses that literally I was like, please do not give me a break. Don't give me a break, because every time you give me a break, my patients are coding in like 3 rooms when I come back from break in 30 minutes. Or, or it's just like they lack kind of sometimes people lack common sense. And it helps to really be innovative and have that fix it kind of attitude and investigative, questioning attitude, but
curiosity, having a curiosity
right.
for knowledge,
and not about being right. So if you're attached to being right, you're going to fail your patients. You're going to fail yourself. It's about, how can I help this patient the most? How can I be their advocate and get them whatever they need? And if I don't know the answer, who do I know who has the answer, and what doctor or nurse can I reach out to? And I will say, our monitor techs, one of them was a doctor in the Philippines. Our monitor techs were incredibly knowledgeable. They trained us on a lot of the rhythms. They were very much on top. They themselves would be looking up what the medications the patients were on, and even our CNAs would look up the H&Ps of the patients and point things out. I mean, so again, when I say I was so lucky where I worked and the great team I worked with, push yourself to do what you can. And I know it's a hard environment when you are in states with 8 patients, 10 patients. That's crazy, but you still have to do your best and ask those right questions. And don't be afraid to be assertive, because we took a lot of new doctors in. I had a doctor once order 200 milligrams hydralazine, Q2 hours PRN. I was like,
do you even hear their blood pressure or their heart rate?
I was like, I was like, and you learn. Look, I was not, if you guys think maybe I'm not so tactful now, imagine me before nursing school. So I had to learn how to speak to humans when I went to nursing school, right? And so I had to learn, oh, this is how you talk to a doctor. Hi, I just want to check and verify, is that actually what you meant to order, or was your finger having a seizure when you entered the order, right? So again, there's a way you question it, but do not go along, because if I had given that medication, I would not have RN after my name today. That patient would be in a body bag.
I think I might even go as far as to say, if you're not asking a provider, a doctor, an NP, a PA, at least in the ER, if you're not asking them at least once a day, so what do you think's going on with this patient? What's going, what do you think it's this? Do you think it's that? I think if you're not doing that, you're not doing your job, because, and they like to teach, doctors, I mean, whether or not they're in a teaching hospital, they've gone through residency, and all the teaching learning is like built into being a physician. So when you say, what do you think is going on? It's like, well, it's really odd. It's funny you should ask, because, they've got this, this, and this. Well, what do you think about the fact that they have this? It's like, that confused me too. And so they'll be happy to talk you through the process most times. And you're learning stuff you never learned in nursing school.
Mm-hmm.
But you may not know just by doing the job. You've got to talk to somebody about what's going on. So the next time you see it, you're like, oh, I remember Dr. So-and-so talked about that like a month ago, right? Yeah. And this is the same thing. I think that's part of the job. I think that's part of keeping up. And for me, it's part of what makes it, is why I enjoy it, is always learning and that kind of thing. And I may have been seen as one of those nurses that wanted to have the approval of the doctors, or I wanted to be a doctor because I got along with the docs much better than I got along with the nurses. Just because I think we spoke the same language, and I was a little more focused on what they're focused on, and not so much about all the little petty details that sometimes nurses get caught up in, about forms being filled out and whatever. But I learned so much that I think it's a benefit to any of us to do that on probably in whatever setting you're in.
And yeah, so you'll learn which ones want to teach you, which ones just want you out of their hair. So from the ones that are willing to teach you, ask questions. Every time you don't know something, look it up. That way you learn about what those conditions are. And repetition is the mother of learning. The more you see it, you will oh, okay, this patient has this, or they're going down because they have gastroparesis, or what's a gastric pacemaker, just different things. And
yeah, your first couple of years of nursing are your busiest, because you're learning, you're looking everything up. And I'm finding I'm bracing myself for that to be what it's like in nurse practitioner school.
mm-hmm.
Every patient I see, I'm going to be looking everything up. What do they got? What's the differential? How do I, what are the protocols for this drug? Next patient, oh, they have a different problem. Okay, I got to look that up. And then after a while, you're like, yeah, I've seen hypertensive patients before. I don't have to look everything up. I know what to do. Let me double check the doses. Okay, we're good. But the first time through all of that is very, very busy, and just, I guess, be ready for it. Like I said, I'm bracing myself for that. It starts in May. Fingers crossed.
So Bridget, what's your story? Let's hear a success story from you.
Oh, okay.
I know you've got a lot of them. I know.
I have several, but probably, and I will admit, so for example, like what you said, Nurse Adrienne, sometimes you don't know what's going on, but something's off. So now that I was teaching psych for so long, I can look back and say, oh, okay, I know what condition that was. But I was working in psych. It was a young patient, and he was young, early 20s. According to the family, had never engaged in this kind of substance abuse. I won't say specifically, I'll try to avoid too much specifics so that, HIPAA, but had done a specific substance and had a psychotic break. So was at our facility and was very manic, was very psychotic, but manic. He had been started on antipsychotics. He was doing better. This is a little diverging a little bit. Always also chart very thoroughly, because I leave the shift, I come back the next day, this person had sustained an injury, and the day shift thought it happened during my shift. And they were saying oh, did you guys call a code because so-and-so has this bruising at this location. And I was like, no, he's completely fine when I left. Well, it turns out that his roommate came forward, and apparently he had taken a stumble and he had got a pretty bad bruise. But I took down a statement, everything, to always protect yourself, document, document, document. So the next day I'm at work, and this patient is just becoming what appears to be increasingly agitated, combative. He was always pleasant. Yes, he was psychotic, but he was pleasant. He started sweating profusely, kind of how I'm right now because I'm so hot. I'm like, the AC's off because it was cold this morning, and I'm like so hot right now. But anyways, so he starts sweating profusely. He starts stripping. He starts running from one end of the hallway to the other as if he's jumping off the wall, like parkour, and just to completely change in cognition. And I'm like, this does not look. So the normal reaction would be to, he's harmed to self. We're going to call chemical restraints. We're going to get an order for more antipsychotic to calm him down because he's very psychotic. But I said, this just, something's different. Like, you just start to get intuition. I separate him just so that he wouldn't hurt himself and other patients. We take him to the seclusion and restraint room. We don't restrain him. We're just trying to calm him down because, again, he was running around. He was sweating profusely. Several techs are just trying to calm him down. We start getting vitals on him. So his systolic blood pressure was through the roof, was like 200. He had a fever, and I'm like, okay, this is an emergency. Like, he's having a reaction to the medication. So now that I teach psych, he had neuroleptic malignant syndrome, which is very rare. Nurse Scott is saying yes, it's very rare, but it's life-threatening. And if you give them more antipsychotic, you could actually unalive them. You don't want to give them any more of that. You can give them some benzos, some cooling blankets, some fluids. But that was one call where I feel like my direct, and also because it was a psych facility, I immediately called my manager. I'm like, something's not right. He's extremely sick. We need an ambulance right now. So we were just a psych hospital. He had to go to the hospital, and he was okay after that. But he never did come back to us though. But even my manager that day was like, good job, so that's one of those stories that just sticks in my mind of, thank God. I just thank God, because it could have gone either way. It could have been really bad, but thankfully it went good. And maybe, the Holy Spirit was looking out for me and kind of enlightening me a little bit, because like I said, sometimes we have to make such tough calls in nursing, and we just pray that it's the right one.
Well,
and it's important to know when there's something just not right. Something's just not right. And that's where it starts. And I think if I understood the way you told the story, now it was neuroleptic malignant syndrome, but at the time you didn't diagnose him with that, but you knew something was wrong, and that's enough sometimes to make a difference.
Correct. We don't always, especially if you're new, you won't always have the answers, but you'll know enough. Just how, for example, Adrian was like, okay, let me ask people what's going on. So you'll know when something is off, and that change in cognition is so important, because I've had stories where unfortunately the nurse on a med tele floor where I was working, I had a patient one day, another nurse gets the patient the next day, completely changing cognition. He was very sexually inappropriate with me, out of the room yelling. The next day, not a peep out of this man, but he wasn't assigned to me because I had asked the nurse that day. I was like, he's the charge. I asked her, he was very sexually inappropriate with me. Please don't give me him tomorrow. Well, I'm working the next day and not a peep out of this man. And I'm like, I even asked the nurse, I'm like, have you checked on so-and-so? Is he okay? Oh yeah, he's been sleeping all day. He had a massive hemorrhagic stroke.
Wow.
So changing cognition is so important.
Adrian says, notice the changes. So this is many, 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 many years ago. Moses was still a kid. I'm working as a CNA. I'm just a CNA working on a high-risk labor unit. High risk being women that are their bodies threatening to abort. They're bleeding. They're having contractions prematurely. We're trying to keep them pregnant. Well, I go in at like 5 o'clock in the morning to do vitals on this particular patient, and I notice as I just take her temperature, she's got blood kind of crusted all over her teeth. I thought, that's weird. So I take her temperature, I get her toothbrush and say, a little bit. I go back in maybe a half an hour later, and she's got a fresh set of blood all over her teeth. I said, "Oh God, she's in DIC."
Oh,
And shit. So I come out to the nurse. I said, "I think she's in DIC. She's in trouble. I'm getting a fresh set of vitals. Get me a needle. I'm going to get me some blood from her. Get me an order for the blood that I'm about to draw." And within a few minutes, we had her downstairs to the ICU. Sure enough, she was in DIC. Some stupid little CNA who picked up on the fact that she had blood in her mouth that kept coming. Her gums were bleeding. She was in DIC. Came back later the next day. They delivered her. She was doing better. She's doing fine. But some stupid little CNA who had been paying attention on the same unit for months.
Not so stupid, I'm thinking.
You can't buy the diploma.
Right.
You can't.
And this is why
bring this full circle now.
You can't buy this
Every-
shit. You can't.
every member of the team, I have had dietary workers go in and deliver a tray and say, "Hey, this patient's acting a little strange, or something's off, or because maybe they saw them for 5 days in a row, a few days in a row, or it's the transporter, it's the tech, it's the
even the other
radiology tech."
patient. I've had other patients come and tell me like, "Hey, my roommate is having a seizure or something,"
I've had
Your best
patients call in
friends-
other patients before.
Yeah, your best friends in the hospital are going to be your respiratory therapist and your pharmacist. And respiratory therapists often, because they work all over the hospital, they're often very familiar with the patients, especially the ones that are the frequent flyers, right? The phlebotomist also very familiar with the patients, So get to know your whole team and appreciate your whole team. I mean, we used to buy our CNAs like every payday, lunch, Christmas cards, gift cards at Christmas, the holidays. Show appreciation for the whole team if you're at the top of that tier of the pay grade. But everybody on the team is so valuable because they really do. They're going to notice the difference, in a lot of these patients, and often that's the thing of, especially with strokes. Like this botulism patient kind of presented as a stroke, right? Because that botulism poisoning is like, it's like there's tremors, but then it's weakening, it's slurred speech, but it's a weakness in the facial muscles. And then, you're not able to swallow. And so it can look like a lot of things. So it's important to, again, we're almost at that level where, because patients are so acute, they're so sick now, the level that we need to be operating at, whether you're in a skilled nursing facility, any kind of nursing, is really high. And unfortunately, we need more of us. We need more staff. We know all those issues, but it's up to us to elevate and support each other in nursing, be kind to each other and be holding each other up and encourage the elevation of, awareness and education amongst our teammates.
And they're all just extra set of eyes, and we sure could use that no matter where you work. And they may not know, what a normal blood pressure is or where your spleen is, but they know when someone's not looking right. And the thing is, they're like, they just don't. He's acting, like you said, they're gonna phrase it very generally, like he's not acting right. They're not gonna say he's having a grand mal seizure or he's got left side hemiparesis or something, because they're the food service worker. But they can say he doesn't look right, or he's drooling, his food's falling out of his mouth, or whatever. And the challenge is not to let our pride get in the way, because every once in a while, you have someone like the transporter come up and says, "I think your patient's having a seizure." It's like, I'm the nurse. I'll decide if he's having a seizure or not. Okay. And then you walk in, it's like, "Oh yeah, he's having a seizure." So don't let your pride get in the way. Like, look, you're a transporter. I don't really need you to assess my patients. Okay. You go to nursing school like I did and get back to me. Okay. That's stupid. Just go check on your patient, because, or the visitor, the roommate or the roommate's visitors or whatever. It takes a moment to check and say, "No, everything looks fine to me. Thanks for letting me know." But to ignore it, you could really shoot yourself in the foot.
That's Maggie, nurse advocate, who just put that comment about IC charge relieving. Yeah. So Maggie is an amazing advocate. She worked for the Board of Nursing in Texas. She was an investigator. She is a huge resource. She's like a policy junkie like me. So she's on TikTok. So follow her on TikTok.
Is that her?
When
Is
the old
that
lady
her
with a mop.
name on TikTok? Nurse Advocates.
Is that it, Meg? I think it is. It's the same symbol.
I'll follow her.
Yeah. I mean, I think the other thing too, and I wanted to say to anybody that's watching who's maybe not an RN, not an LVN, if you work in healthcare and you see something wrong or something that doesn't make sense, do not be afraid to pull that code button or to yell for help or to ask for help. And don't let if you know something's not right with a patient, because patients go off the floor for all kinds of things. You know, I mean, we had a transporter who brought up a patient who expired between the somehow expired between the ER and tele and our floor, 2 floors. And you know, he went on to, and this poor kid was like ghost white when he came off the elevator because he had no idea what to do. But he went on to become an amazing ER nurse. And so, you know, always say something, always say something. And if you're not getting, I mean, my mom was chronically ill in the hospital quite a bit. It was oftentimes, you know, an aide or somebody or a dietary worker pulling me aside to say, hey, this is going on, you know, and don't always, we all can make mistakes. We can each make mistakes and seeing something. So be that advocate, be that voice. That's what it's all about.
I want to give a shout out to Yavel because he made and you put this up on the screen, but about him being a transporter. That was my first job in the hospital, was a transporter / messenger. And I schlepped patients from one end of the hospital to another. And it was a great way to start a career because you got to see the whole hospital. I can still draw you a map of that entire hospital as it was then. They've added on to it now, but I know my way around the whole thing. I know the places you can sneak a nap. I know the fastest way to get to a code. Yeah, it's great. And transporters, you think all they do is they push gurneys and wheelchairs, but they're a set of eyes too. And everybody in healthcare learns at least a little. I mean, our volunteers sometimes knew more than you expected them just by mere exposure to the healthcare arena, which kind of ties into why clinicals are important in nursing school, because you have that. You don't learn everything. You don't learn everything in school. You don't come out of school going, bring it on, I'm all ready to do my job 100%. No, but you've got the basics and and you know how it all works, and you've got the knowledge base to start training for your job. And so, yeah, you have to have clinicals to get that. You need a little of that before you get out.
And that's why the people that were kind of attacking me for saying how important clinicals were, it's like, how can you, when you don't partake in something, you don't know how valuable it is because you have nothing to compare it to. You know, if you did clinicals and you tell me, okay, they weren't that valuable, okay, I'll respect that because you went through it. But you can't tell me clinicals aren't valuable if you never went through them.
Yeah. I look back and I'm
absolutely.
like, did I really learn anything in my clinicals? I'm like, well, I don't think so. But at the very least, I'm sure I did. It's been a long time. But at the very least, it exposes you to the role. It exposes you to the
How
setting.
to talk to a patient is so important. How to just be in a room with them.
Oh, yeah. So my first time, it was med-surg. Maybe it was even later. But anyway, I had to go in and say, hi, my name is Scott. I'll be your student nurse. And just those words coming out of my mouth felt like so weird and strange. It was like I was speaking another language. And of course, you know, in no time, you're just like, hi, my name is Scott. I'm going to be your nurse today. So what brings you in? It just rolls off the tongue. But at first, it's weird to introduce you. Even the introduction is awkward. But after a while, you get your pattern. You know how to ask your questions. And all that starts in clinicals and nursing school. It doesn't end there for sure, but it sure does start.
I remember when we would have to go the day before and be assigned a patient. And I just remember my teacher saying, okay, well, go introduce yourself. And I was like, I just knock on the door. Like, I was so scared to even just like knock and be like, hi, I will be your nursing student tomorrow.
I'm sorry to bother you. I know you're busy being sick and all, but yeah. And that's what's nice about the career in general. I get all philosophical about the whole profession, but you learn to speak to people in different times in their lives. And sometimes you don't learn, like I did when my dad died. We've always tiptoe around people when they're grieving and someone has just died. You're like, oh, man, don't talk to them. They just lost someone, or, and granted, you want to be respectful, but they're really, now I'm knowing it from the other side. There's nothing anyone could have said to upset me. I was so focused on my grief and my family and how everyone's doing that if someone said, hey, I need you to sign some papers, it would have been that, sure, I'd be happy to. It's not like, can't you see we're grieving? We just lost our father. You're asking me papers? No. So sometimes it takes learning it from the other side. But you do learn to kind of be respectful and realize that it's okay to talk to people who are busy being sick, to introduce yourself as a student nurse. It's okay when people are grieving and to go, when you have time, there's a form, don't leave without signing this form that I have for you, but you take the time you need, and that becomes comfortable to you. If you think it sounds like an awkward thing to do, it gets easier over time. And I think that's also one of the beauties of the profession is now I feel like I can talk to anybody about anything. At least I can at least get a start. I interviewed, for this last project, I interviewed our city supervisor. San Francisco has a mayor and then a board of supervisors. And I needed to interview someone for this project, and I had a great conversation. I didn't feel intimidated by him, anything like that. I think that comes from experience in the profession.
I definitely do they consider those soft skills, like those skills that you would not necessarily think you would gain, but just talking to people, being more perhaps assertive, or all these taking leadership roles that necessarily they don't put on job description, but that you learn in nursing.
They don't use it on a job an annual evaluation either. You're like, you didn't do this, you didn't do that, you didn't do that. It's like, yeah, but do you know how amazing I was with that family who was grieving? Yeah. Do you know how amazing I was talking to that 12-year-old about why he needed a testicular ultrasound to rule out torsion when it was the most embarrassing thing he could imagine? I had to do that once. And I'm like, dude, I know no one wants to talk about this. It's very private, all that, but here's why it's important. Does that show up on my evaluation? No. So you have to also have an internal sense of satisfaction.
You do. Absolutely. And I think it's also, some of we've got this giant generation, Gen Z, right? And there's it's called the privilege of youth, being cavalier, knowing all the answers, right? And being able to judge everybody who came before you. But I also understand that when you're like under 30, most of us, I'm an exception because my family was all like 100 years old when I was a kid. Most of us don't have to deal and have not actually experienced the grieving process personally, and have not even had to deal with a family member being ill or chronically ill or near death, and had to be in a hospital and really had something at stake. Right. So we many people do nursing or do their job without having, from the philosophical level or the financial level or whatever. But once you have somebody you care about in that bed, it all changes. And for me, I was lucky enough. I was in that place for my whole life until I became a nurse. And I became a nurse after my mother passed, after my father passed, after many, many people when my family passed. And I had so much experience with the healthcare system. That's what drove me to be the best advocate I could be and not take things personally, not be cavalier about anything, because I have seen the best nurses have, miss something that, they could have been fired for, right? In reality, my mother was coded by a nurse, when she was a DNR, but it was a new nurse. So just understand, if you're younger or haven't had to deal with a family member in that bed, have some humility about that. Yeah, there are people who really understand that. Because I used to feel very bad for young nurses who would come out, and I would see them really struggle with patients who passed. I mean, how do you talk to somebody whose family members just passed away and you're 22 years old and you've never even had that conversation? You've never even seen that conversation personally happen. Whether or not I want to say it's a benefit, I also had the experience of dealing, being in the AIDS crisis and going to hundreds of funerals. So I don't know what it's like for people who don't have that experience. And I know it must be hard. It must be challenging. Well, I mean, your father did pass, and
No, but I mean, that was in my 40s. So I remember what it's like to be a new nurse, and I kind of got a kick out of it. I'm like, I have nothing in common with this person. They're in a gang in the inner city of St. Louis. I'm from the suburbs. But we did it. We connected. Yeah. I got his ID started. We talked about that, and we found our humanity. And it does get better as you have. I always say the longer I do nursing, the more I can relate to all the diseases because I've had them. It's like appendicitis, I've had that. Oh, cataracts, I've had that. Oh, XYZ, I've had that. But even if you don't, you're right out of nursing school. You've never had an STD. You've never had surgery. Your parents are alive and well. And I mean, I also didn't have kids in my family until later when I became an uncle. But doesn't mean I can't learn how to relate to kids. And it's fun to learn. So just be patient with yourself and don't think, well, maybe if it happened in my family, then I could be able to talk to someone about
Sometimes it's
whatever. But you can.
it's the
even
blind
without it.
spots. It's the things we don't know that we don't know.
Well, there's that. Yeah.
Right. I mean, that's the privilege of youth, that we can have so many blind spots and think we know everything. But there's so much as we learn that we don't know.
Yeah.
Right.
At all stages of life, actually.
Yeah, putting our egos aside, being humble, realizing that we don't have all the answers and that we are constantly learning every day as a nurse.
We are always learning. And I mean, I have been away from the bedside for a couple of years now. And, I think, oh, maybe I'll, go get a job in a clinic or something. And even me, I'm like, oh my gosh, I got to like brush up on this skill. I got to practice my pharmacology, am I going to be able to start an IV again? All those things go through my mind, but that's humility. That's being humble and wanting to not do harm, wanting to be the best I can be when that person could be having the worst day of their life in front of me.
Well, that can be scary. See, now I'm doing this whole nursing school thing over again, kind of by training to be an NP and knowing there's a lot I don't know. But that can also be terrifying. It's like, I have no idea how to take care of these patients in clinical, and I start in a couple of months. But acknowledging I don't know everything, but that also that I am learning, I do know something, and that I have resources. I have my preceptor, I have my faculty, I have my books, and I have
And
up-to-date
guidelines. Yes. Oh, I love guidelines.
Guidelines.
Yeah. So
Hypertension algorithm. This, that, like.
So it's good to know that you don't know, but don't let that also frighten you, because
and we have this.
That's where we all start. What is that?
Well, I mean, always
imagine
said
before cell phones, like,
Exactly.
holy cow.
I always said the measure of a good nurse is you know what you need to know, but you also know what you don't know, and you acknowledge that.
And you have respect for that.
Yes,
you have respect for that. There's nobody
I don't know.
who knows
I
it
have
all.
to go get help. I need to go get help. I need to ask someone else because I don't know.
And don't be afraid if you get a patient that you are not comfortable with, like if they're presenting in some way that you just are not familiar, that's not the right patient for you. I mean, they would try and give us OB patients, postpartum or pregnant women and on telly, and we would just be, nope, NO, capital N, capital O, I'm going to leave. I'm going to call out sick right now. I'm going to go home with a migraine. Bring an OB nurse, an L&D nurse up, hit the bedside, and we would make them have an L&D nurse there the entire day, because they're like, I am not qualified at 1 o'clock, nor am I qualified at 2 o'clock or at 3 o'clock. I am not qualified, and I'm not going to put my license on this patient. Peace. You know what I mean? And we hold the line. Adrian. Hold the line, you guys.
I'll keep my OB patients. You keep your tele patients.
Right. I mean, hold the line.
Never
on your skill set.
meet.
Yeah, because it's like, I don't know. I mean, my L&D OB, that was not, I slapped a dad. That was my highlight of my experience. I slapped a dad awake who passed out because the doctor told me to do it. He told me to slap him.
Oh, well, the doctor told you to do it.
The nurse left the room and I was left alone. And then the father just dropped to the floor as the baby is coming out. And I was like, what? And I did try to wake him up, just so you guys know. I did try, but he
let him sleep.
The doctor was just like, slap him. And I'm like 220, you guys, and I was a shot putter. I'm like, okay. Yeah, he woke up.
Did you slap him or punch him? What did you say?
Yeah, how are you sure it was just a slap?
Okay. I think that we can wrap up now. Thank you so much for being here, all of you. I really, really appreciate it. I think we touched on the diploma thing. We veered off a little bit, but I think it's all relevant, and I think that they will appreciate it. So.
Have you met us?
I think what we're talking about is
we are ADHD personified.
You can't buy this experience. You can't put down $10,000 and gain the experience that we've had. That's what makes us who we are, is the little tidbits we've picked up from here and there and what we've seen and what we've done. And you can't buy that.
It starts with a foundation.
Those are the closing words.
As much as we want to poo-poo nursing school sometimes, like they didn't teach us what I need to know, and my instructors have no real clinical experience, they're all academics, blah, blah, blah. It's still the base. It's the foundation for the rest of it.
Thanks, Bridget, for hosting the
Yeah,
live.
thank you, Bridget.
And,
My pleasure.
we miss Liz. Is Liz next week? Is she here or no? I can't remember.
I think next
I think
week
she's-
we'll be back on Nurse Liz's channel
I
on
won't.
Friday. Oh,
You
but
won't.
minus Scott.
Minus me, I'm getting my eye work done.
Okay. Are you okay? All right. We'll talk about
I
that
haven't-
later.